to get you fixed up here.
Oh. Well, thank you, Leslie, for that wonderful introduction. My goodness. I'm going to speak today about on rehabilitation pathways to pain management. Okay, thank you. The objectives of my talk are to define the mechanisms involved in chronic pain of nociceptive and neuropathic origin, also to discuss trends in the approach to medical management, and to describe multidisciplinary interventions needed to address the medical, psychosocial, and functional aspects of pain management. According to the IASP, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. As practitioners and caregivers within the various healthcare fields, we are all too familiar with the devastation that this usually temporary, unpleasant experience can have on our patients and their families when it persists. How does something so basic and necessary to our health and well-being become identified as a public health problem because of its negative impact on so many lives? It has become clear that managing pain is an essential and successful part of managing patient care as body temperature. Clinically, pain is now defined as and identified as a fifth vital sign, emphasizing its role in the ongoing care of our patients as well as in the assessment and diagnosis. The present focus on pain research as in the area of greater importance this year, and the intense interest in the field has led to the designation of this first decade of the 21st century as being the decade of pain control and research. No doubt, from the beginning of time, healers have asked, where does it hurt? Why does it hurt? How does it hurt? Now we know something of the extent to which persistent pain negatively influences patient outcomes. We are no longer settling for where and how, but seeking to know what. What can we do as healthcare providers to alleviate suffering that too frequently becomes a block to recovery and management of illness? In looking at the epidemiology of pain, the prevalence of chronic pain in the United States is 30 to 40% of all adults approximately, and neuropathic pain is at least 4 million cases in the United States. And looking at chronic pain in children, it's about 15 to 20% of children. It's not just a health problem within the United States. If we look at Europe, we can see that places like Italy, Portland, and Norway do approximate our percentages in terms of people being affected by this issue of chronic pain. Estimated prevalence of neuropathic pain in the United States, primarily most of it is with low back pain. And you can see that there is an area, the blue area is post-herpetic the post-herpetic neuralgia is actually red, and diabetic neuropathy is blue. In perspective to our population of the neurological patients, MS has a small percentage, but although they encompass a small percentage of the overall patients affected, pain is a severe problem within this population itself. Epidemiology in terms of how much it costs. 50 million patients suffer from chronic pain, non-malignant pain, which is greater than 3 months. It's very costly. 40 million physician office visits each year, 4 billion lost work days, $65 billion in lost work productivity, and $3 billion in over-the-counter analgesics. When you look at neuroimmunological diseases in adults, MS is about 1 in 750 people, and the report is about 42 to 65% of these patients report pain. GPS, 1 to 300,000 per year, and about 40 to 50% of these patients have chronic pain symptoms. And transverse myelitis, 1,400 new cases a year, and it's 33 to 50% of the patients in this case. When you're looking at peds, the incidence is much lower, 2.5 cases per 100,000 children. GBS is very low, 0.6 to 2 cases per 100,000, and TM is even lower, 1 to 4 cases per million children. And ADM, acute demyelinating encephalomyelitis, is even rarer. What I wanted to point out here is lack of data with kids and being reported with chronic pain issues. Most of the chronic pain in kids is reported as recurrent abdominal pain, headache, etc., but not too much neuropathic pain. When you're looking at pain, you can really split it off into two broad categories, adaptive pain and maladaptive pain. Nociceptive pain and neuropathic pain are going to be my areas of discussion today, given the population that we're discussing. There's another terminology that's being used, and that's eudynia, and that means good pain, and neuropathic is bad pain. And it's felt that our patient population primarily suffers from a combination of the two of these types of pains. Nociceptive pain is postoperative pain, low back pain, injury pain, and arthritis. In discussing neuropathic pain with adults, it's well studied. You have both a peripheral and central types of neuropathic pain. Peripheral being your postherpetic neuralgia, your polyneuropathies, central pain being post-stroke pain, multiple sclerosis, spinal cord injury pain. In children, although it hasn't been studied, the incidence, but there is mention in Dr. Sharisha's article that they have post-amputation pain, spinal cord injury pain, and pain during Guillain-Barré and multiple sclerosis. The peripheral mechanisms, pain lesions can occur anywhere when you're talking about neuropathic pain within the peripheral and central nervous system. This is an axon and cell body. And considering different mechanisms of pain, nociceptive pain is a pain that's very protective response. It's a familiar pain that we have where we perceive stimulus that's not pleasant feeling and we quickly withdraw. If, in fact, there's some tissue damage, we may experience some inflammatory pain in which there's vasodilatation, redness, increased swelling, and as a result, we have decreased motion. And that's actually protective, and it allows healing to take place and for us to also have repair. Both nociceptive and inflammatory pain are adaptive forms of pain. When looking at neuropathic pain, it's maladaptive, and as I said before, it can be secondary to a lesion within the peripheral and central nervous system. When you're looking at the contribution of the primary sensory neuron to pain, from a nociceptive standpoint, this system acts as a filtering system in which usually most of the stimuli are not really strong enough to elicit any type of activation. But if you do get a stimulus that's actually strong enough, you're going to have transduction occur. And with transduction, there are going to be some changes in the ion channels in that membrane, especially sodium. Sodium is going to go into the cell. There's a process which is very familiar in terms of pain production. It's peripheral sensitization. This is where tissue damage occurs, and you have the cells that are damaged giving off chemical mediators, and they're like adenosine triphosphate, potassium, lowering the pH of the system and making it more easily to have the cell depolarize. Also, you have inflammatory cells being recruited in this process, and they too are giving off mediators. The important point here, though, is that the nociceptors either become activated or sensitized during this time, and there's a lot of depolarization that takes place and excitability. They call this peripheral sensitization. You may have heard of that term. And what's happening is there's a decreased threshold of nociceptors. There are ectopic discharges which occur and abnormal accumulation of sodium channels. And lastly, there's a transcriptional change that takes place. And this change results in increase in potassium and sodium, which leads the membrane to depolarize a lot quicker. And the discharges are ectopic, and they don't need to be generated by stimuli. Regarding contributions of the spinal cord dorsal horn neurons to pain, basically centralization is seeing that there's amplification and facilitation of neurotransmitter response so that the impulse of pain gets transmitted. And backing up with that peripheral system, a target or an area in which pharmacological therapy can be intervened is at the receptor site, the presynaptic receptor site, in which those receptors control transmission of neurotransmitters. And if, in fact, you have opioids, cannabinoids, and even gabapentin, you can inhibit neurotransmission through that synaptic cleft. With central sensitization, it's much like peripheral sensitization in that there are a lot of mediators taking place within the pathway and making the overall environment a lot more sensitive. Pain sensitivity occurs beyond the area of tissue injury. Stimuli of low threshold alpha-beta receptors generate sensations of pain or tenderness. And the hallmark is that normally pain fibers which are not strong enough to have signals of pain transmitted now do. This is just a reminder, basically, of the support cells outside of the system which are also involved, and they too give off chemical mediators in this process. The interesting thing about these cells is that they have the ability to transform into other types of cells. They call this neuroplasticity. This is an overall view of the system in terms of peripheral stimulation from pain going through the spinal cord and then the hypothalamus and to the sensory cortex. And then there's a modulation on the system from the midbrain down to the peripheral cord again. Lastly, genetics plays an important factor in all of this. You could have two people with the same disease, the same lesions, and one have pain and the other not. The same is in response to the analgesics and also the pleomorphisms of drug metabolizing enzymes. Overall, in understanding the approach to neuropathic pain, how it occurs, you look at it from the disease process, then you look in terms of what's happening at the pathophysiological level, then you look at the symptoms and you look at the syndrome. As clinicians, we are assessing pain or assessing the patient at all times. An important part of this assessment is the history, of course, and this is where you get your information from the patient as to how long, how did this occur, what are the things that characterize the pain, anything making it better, anything making it worse. You also ask the patient about comorbid conditions which could be contributing to the pain process. You want to know whether or not they've been on therapy before, what was their response to treatments, and if the treatments had adequate trial periods. You want to know about the functional status, the mood, and the sleep patterns as well. In assessing neuropathic pain, you have two types of pain, one that's stimulus elicited and the other one that's stimulus independent. Stimulus independent is one most of us are more familiar with. You have that constant burning described, that electric shocking, lancinating pain. Paresthesias, dysesthesias may sometimes be mentioned. And those that are stimulus elicited are allodynia, in which these are usually non-painful stimuli that are now perceived as painful. And you have hypoalgesia, in which you have a painful stimulus that becomes more painful. It's an overreaction. You have some assessment tools which are used in terms of the visual analog scale. This scale is very well accepted and very well accepted and widely received. It's used in a lot of studies. It basically measures the intensity of pain. The thing I like about the visual analog scale is that we can use it in pediatrics as well. Children 5 and up are able to use the scale. When you think about assessing a child, 0 to 3, they're not able to communicate any characteristics of pain, so you mainly make your assessments based on their behavior. Other measures would be neuropathic pain scale and the LAND scale. These two scales were pretty much meant to separate nociceptive pain from neuropathic pain, but they haven't been validated. And a multi-dimensional scale is the McGill questionnaire scale. Your physical exam is extremely important. You're going to look for functional motor testing in terms of positive and negative motor phenomena. Negative motor phenomena would be weakness, clumsiness, decreased endurance. Positive motor phenomena would be dystonia, ataxia, and tremors. Your sensory exam is a huge part of your exam in neuropathic pain. Your patients, given various stimuli like pinprick, soft touch, they may or may not have an increased or decreased response. Decreased response, hypoalgesic, would be the negative sensory, and increased response would be the positive sensory. And neurologically, you're always looking for to rule out focal findings, which may be part of that exam. This is a clip, and I'm not quite sure you'll hear the audio on it. This is of a patient giving a very descriptive talk on his pain. Is there any audio? None. Okay. What he's doing basically is describing where the pain is located, and he's stating that he perceives it to be like a sea urchin, that little wiggle worm, and that it's really hiding out, and it's very, very hot is what he's describing, and that, you know, with different movements, and if somebody touches him, it becomes excruciating, unbearable pain. And one of the things further in the evaluation that you would see when he's examined is he has a very hyperactive reflex when the area is touched just with the finger of the examiner. You can turn it off because we can't hear his description. So. With further assessment of pain, you're looking at objective measurements in which, apologize, allows the mapping, and it shows area of activation in the pain process. So you can see at top there's no pain, there's no activated area, and below there is. When forming a treatment plan, we always set goals. And of course, in this instance, our goal would be to modify the pain process, if not abate it. But it's unlikely that this will happen. One of the things that I really want to emphasize here, though, is that you have to have an approach multimodality and multidisciplinary, in that the pain is only one factor. There are other psychological stressors that are contributing to this picture. So one of the things you want to do is increase the quality of life. You want to increase sleeping, mood. So you're always looking to not just treat the biological problem, but treat the other concurrent problems which may be adding to the process. When you look at a different approach, pharmacologically, a lot of times a mechanistic approach is given. And this gives you an overview pretty much of the areas of pharmacological intervention within the peripheral and central nervous system. The trend today, though, is to go more towards symptom-based therapy. It's felt that you get better outcomes that way. A lot of times with just treating the underlying disease, you don't get significant results. So this is just a little chart showing which drugs have been shown to be effective in the different types of symptoms. When you're looking at choices that have been actually studied, there was an excellent article from the Archives of Neurology and Advances in Neuropathic Pain. And what they did was looked at 100 randomized studies, and they determined from those studies which drugs were shown to be efficacious. Gabapentin and these drugs, which were the most efficacious, were put on as frontline medications in the management of neuropathic pain. Gabapentin was very effective in both peripheral and central neuropathic pain. It's titrated up, and the maximum dose is about 3,600 milligrams per day. And you can't go beyond that because there's no more absorbency. What was found was that some of the side effects would be dizziness, somnolence, and some peripheral edema, some GI problems. But overall, gabapentin has been a very good drug for both types of pain. A good pain trial is about 3 to 8 weeks with the gabapentin once you get to therapeutic level. And in terms of postherpetic neuralgia, that lidocaine patch has been found to be very efficacious. It's well tolerated, and usually there's a maximum of 3 patches per day. The only side effect with this is skin local irritation. Opioid analgesics, they've been a source of controversy for quite some time in pain. At one time, it was not advocated that they're used in pain management, but now the studies are showing that they're very efficacious, and not only by themselves, but in combinations as well. The recommendation is to start them with low-dose short-acting, and this would be for a couple of weeks, and then change them over to long-acting opioids, and only using the short-acting for breakthrough pain. With opioids, you always worry about substance abuse, and in patients who have had a prior history of substance abuse, it's not contraindicated to start the use. And you always wonder about when you start patients who haven't had a prior history of that, what's the risk of them becoming substance abusers? And this has not been studied, but overall the recommendations are that they're carefully monitored and that there's a lot of documentation with these patients. Side effects would be constipation, somnolence, and nausea. With all of these medications, except for the patch, there's a warning in use with the elderly, especially impairing their cognitive function and also mobility problems as well. With gabapentin, renal function is very important. Tramadol and SSRI has been found to be effective peripherally. And just going down quickly to those tricyclic antidepressants, which have been around for a long time in the management of neuropathic pain, who have been found to be very efficacious. However, their side effect profile is huge. And in patients who have a pre-existing problem cardiovascular-wise, it's really advocated that you get a baseline EKG prior to starting them on a therapy. Anticholinergic symptoms such as urinary retention and others are worrisome, and also the tendency towards suicide is also very worrisome. If it were only that easy. An evidence-based approach, you want to know how you're doing. Is this the actual medication for this symptom that's being described? And in the Annals of Internal Medicine, there was a very good study in which it was a meta-analysis showing the efficacy of certain drugs in both peripheral and neuropathic pain. What they looked at was basically efficacy and safety. And in looking at efficacy, it was the number needed to treat. And this was the number of patients needed to have. One patient said they have at least 50% relief in pain. And the number needed to harm was the number of patients needed to say that they had adverse effects. In this meta-analysis study, tricyclic antidepressants as well as gabapentin and pregabalin were studied. And it was found that tricyclics really had a very low need to treat score. Gabapentin and pregabalin were close, but pregabalin actually had a lower number to treat score, but the other number in terms of harm, they had more side effects. Factors which influence pain perception are multiple. The biological we've spoken of, the psychological, and the social and cultural problems are also involved in this process or perception. Management of the psych problems, usually you have various psych modalities which you use. Stress management, which is visual imagery or hypnosis or relaxation techniques can be implemented. Cognitive behavioral therapy, in which the patient's thought process as to how they perceive their pain and whether or not they're able to control their pain. If they describe things as being catastrophic, they're worked on, and they have thought monitoring therapy, cognitive restructuring, and setting goals. And there's also a supportive psychotherapy piece to this management. And looking at rehabilitation, patients a lot of times are deconditioned. Muscle strengthening, soft tissue stretching, bracing, and modalities are often used in this population, heat and cold. The Cochrane review was just done on TENS, and to my surprise, they really didn't find any sufficient evidence saying that it was very effective in this population of chronic pain patients. And exploring alternative measures, I always wanted to look at that. You know, complementary and alternative medicine is being much more received within the traditional medicine practice. One of the studies was showing that actually people with chronic pain and disabilities were more likely to access alternative medicine practitioner in the overall management of their symptoms. Acupuncture, acupressure, massage, vitamins, and herbs are looked at. They've done a lot of studies, or they're now looking at the use of alternative medicine in pediatrics and helping with various types of pain, especially massage with the myofascial and the arthritis. And they are coming out with some positive results. This obviously is an area that needs to be further explored. And in conclusion, it's an understanding that the management of chronic pain, both nociceptive and neuropathic, is complex, and it necessitates an in-depth assessment and multidisciplinary plan. Information is rapidly changing in this area, some of which I said today probably won't be pertinent or important within the next year maybe. And there's also an increased understanding, so the information is rapidly changing. And despite major advances, there are still significant limitations in assessment tools. Thank you.